This month, our webcast is focused on stroke, specifically ischemic stroke. Stroke is the fifth most common cause of death, with 750,000 people suffering from the disease annually. While the rate of stroke cases is declining year over year, stroke is still a major cause of morbidity and mortality. Stroke is classified by cause, with each type being treated differently, although the goal of treatment is the same: save brain tissue. As a critical care transport provider, it's important for you to be able to differentiate between the types of stroke and understand the pathophysiology behind the disease. Now let's get into today's webcast. Death by clot, ischemic stroke pathophysiology. Flybridge Ed has an important mission to bring pre-hospital critical care and emergency medicine education to everyone, because you never get a second chance to save a life.
Everybody, welcome to Death by Clot, Dissecting Ischemic Stroke. Objectives: we're going to define the anatomy of the anterior, the middle, and the posterior portion of the brain. We're going to discuss the signs and symptoms of ischemic stroke, focusing on thrombotic and embolic strokes, and identify the different stroke assessment tools with a focus on pharmacology. If we start off with the anatomy, what we're going to really focus on are the three major vessels that feed the outer and inner hemispheres of the brain, specifically the anterior cerebral artery, the middle cerebral artery, which encompasses the anterior part of the brain. And then we're going to look at the posterior part of the brain and look at the posterior cerebral artery, the vertebral artery, and the basilar artery. And we know that a lot of strokes happen really based on thrombotic and embolic etiology. A lot of the embolic etiology arrive in the brain based on the internal carotid artery. If we look at the base of the brain and we can see the vascularity of all the veins and arteries, really the area I want to focus on is the circle of Willis. And you can see this is an amazing network of vessels that meet in the center and then feed off in all directions. Areas I want to really point out again, when we think about anterior strokes, that's encompassing the anterior cerebral artery right here and the middle cerebral artery right here and here. When we look specifically at the circle of Willis, one of the areas that I want to always point out is when we talk about subarachnoid hemorrhages from a medical standpoint, those Barry aneurysms, 40% of all Barry aneurysms originate right here in this location called the anterior communicating artery. And we know that subarachnoid hemorrhages, most of them originate from trauma-related etiology, but we have a huge portion of bleeds that happen based on that subarachnoid hemorrhage that originate really based on accelerated jumps in blood pressure or those hypertensive crises. You can see that we have the posterior portion of the brain, and that is the posterior cerebral artery that come off both sides, and this massive vessel here in the center called the basilar artery. When we talk about basilar artery embolic strokes or thrombotic strokes, those carry about an 87 to 90% mortality rate. But really, everything is happening in this area of the brain. If we look at the lateral and medial surfaces of the brain, really, again, as I said, we're going to focus on three main vessels with a secondary focus on the basilar and vertebral arteries. And that's the anterior cerebral artery and middle cerebral artery, these two locations here. And then obviously the posterior cerebral artery that is a less common type of stroke. Let's start off with embolic strokes. And really, when we think about ischemic strokes in general, 75% of all strokes are ischemic in nature, with the remaining 25% being deemed hemorrhagic. Embolic strokes most often originate from the heart, where we have atherosclerosis. We have those vessels, and we have plaque rupture, and that little bit of plaque then ends up moving up to the brain through that internal carotid artery into that circulation. When we compare that with thrombotic strokes are more localized strokes. They're focused on those areas inside the brain, and that's based on diseased vessels, just like we saw in the heart. But those are strokes that we deem as lacunar strokes or watershed strokes, which we're going to actually do focused assessments on here in a second. When we look at a lacunar stroke specifically, these originate based on long-standing hypertension. They affect areas of the brain, the midbrain, the thalamus, basal ganglia. And so when you talk about lacunar strokes, you're always really focusing your attention on deep in the brain type of ischemic processes. They're identified based on CT and MRI studies, but any lacunar stroke, they're always going to rule out a subarachnoid hemorrhage as the primary etiology first. Again, a lot of baryaneurysms, subarachnoid hemorrhages are originating from a hypertensive accelerated jump in that blood pressure. When we compare that with a watershed stroke, these are global blood loss strokes, essentially where you're losing blood loss in these border zones. And even though these strokes don't encompass a lot as far as percentages, when you think about all ischemic strokes, only 5 to 10%, they can be pretty catastrophic. Again, based on blood loss, ischemic processes in these border zones. These are going to be embolic in nature, usually based on arterial stenosis, plaque rupture. If we look at this from assessment and really dive into what's happening inside the brain, what you're going to see here is the arterial system inside the brain is all about perfusing the brain from the outer hemispheres inside to the middle. And then obviously we have vessels that do just the opposite. They move from the middle hemispheres to the outer hemispheres. Those arteries that are supplying blood from the inner and outer to inner are specifically the anterior cerebral, middle cerebral, posterior cerebral arteries. And so if you have strokes that affect those middle areas, those watershed strokes then happen, and that's where you start seeing those ischemic processes. So they're border zone strokes. Essentially, you have areas between where you have overlap in that blood circulation in those areas. And here's a great example of a CT scan showing specifically the superior frontal sulcus. You can see the middle cerebral artery, the anterior cerebral artery, where you have overlap in that area. If you have a stroke that is fed by both of those vessels or affects both of those circulation points, that's where you're going to see watershed strokes. So if we focus specifically on the anterior circulation and strokes that are based on that location, these are the most common. They are 70% of all strokes. And really it's important to understand that the anterior cerebral artery, the middle cerebral artery, they really dominate our cardiac output needs inside our brain with 40%. It's important to understand where these originate. They originate based on a breakdown in the walls of the aortic arch. That's called an atheroma. And then we have obviously embolic disease processes where we have plaque rupture, again, that travels up through the heart into the brain through that internal carotid artery. When we focus on the vessels that encompass the anterior surface of the brain, that is, again, the anterior cerebral artery. And then we're going to focus on the middle cerebral artery. And that is all about the medial portion of the frontal and parietal lobes and what's called the corpus callosum. And so these patients are going to exhibit multiple clinical symptoms, contralateral paralysis, that apathy. They really have a very flat affect, urinary incontinence. They're going to be very confused, and they're going to have what's called gait apraxias, where they just have the inability to have proper gait. They can't stand very well. They may have balance issues, etc. When you compare that to the middle cerebral arteries are going to be the dominant area where you have anterior surface strokes. 90% of all anterior strokes are related to that middle cerebral artery. And so That is encompassing the parietal, the frontal, and temporal lobes. Just like we saw with anterior cerebral artery, you're going to have contralateral hemiparesis, you're going to have dysarthria, you're going to have aphasic speech problems, and something called contralateral homogeneous hemianopsia. And so if we look at anarthria, dysarthria, essentially that is a motor speech disorder that occurs when someone can't coordinate or control their muscles used for speaking. And then when you talk about hemianopsia, it's a condition which people only see one side, right or left, of the visual world in each eye. The person may not be aware, honestly, that the vision is lost or happening in both eyes. They may just feel like it's one eye over the other. So, as I said, middle cerebral artery strokes encompass 90% of all anterior strokes. Very, very common, fed by that internal carotid artery. And then when we look at the other side, the posterior circulation stroke, 20% of our cardiac output is devoted to this area of the brain. This is where you're going to also see atherosclerotic vessels that really focusing on embolic strokes. And we see a lot of these strokes that come from our heart, as we all know. When we think about the posterior circulation, really this is where we get into the brainstem, you get into the cerebellum, the cerebral cortex. And as I alluded to when we looked at the circle of Willis, that's where you have the basilar artery. And that basilar artery is a massive vessel. Again, big embolic strokes. And these encompass 87% mortality. So very ominous when you see a basilar artery stroke. These patients are going to have full paralysis. They're going to have, as we talked about, anarthria, dysarthria, the inability to use muscles required for speech, balance, gait problems. They're going to have paralysis of the eyes, and then they're going to have that hemianopsia where they only see, one side of their visual field. If we continue and look at the posterior surface of the brain, obviously we just touched on the basilar artery, the vertebral artery, but we have to talk about the posterior cerebral artery. And that's where we know that artery specifically feeds the hippocampus, the occipital region, the thalamus region of the brain. These patients are going to have severe memory loss. They're going to have left-sided aphasia. They're going to have unilateral cortical blindness. And again, they're going to have that hemianopsia that's contralateral. And we know that middle cerebral artery strokes are going to be 90% of all anterior surface strokes. Posterior cerebral artery strokes, really, when you think about these strokes, most often they're more associated with the basilar artery or the vertebral artery. So lower incidence of overall strokes as a percentage that focus on that posterior cerebral artery. How do we assess our patients from a stroke standpoint? I think it's all about recognition. And when we think about stroke assessment, I know in the pre-hospital setting, we have used the Cincinnati Pre-Hospital Stroke Scale for a lot of years, and I think that's still a very common standard around the United States. Obviously, we have listeners listening to this lecture that are nurses as well, and so we're going to touch on what happens in the hospital, but I want to hit on both of these just so we're aware of what each other does and why. Really, from a pre-hospital standpoint, it's about early recognition. It's about getting a patient from point A to point B in a stabilized manner and get them to definitive care. And so it's about quick early recognition. And that's what the Cincinnati Pre-Hospital Stroke Scale really, in my mind, does. You're looking at three areas: facial droop, arm drift, and speech. Either it's normal or abnormal. Very, very easy to identify an abnormal finding. But we know that we need a more extensive assessment once we're in the hospital setting. And that's where we look at what's called the NIH stroke scale. And really, it's all about quantitative measurements of stroke-related neurological deficit. So it's a great evaluation for severity. It looks at specifically the best approach for treatment, and it's a great predictor of outcomes. If we look at this, you can see that it is extremely in-depth. And, it looks from level of consciousness. You can see visual, gaze, facial paralysis, moves down into the arms, the legs, sensory, talks about language, dysarthria. And so it's all about a thorough assessment. So how do we evaluate the NIH stroke scale from a treatment standpoint? Really, Anytime you have an NIH scale greater than 4 is considered a moderate stroke. These patients, if they're within a window of 4.5 to 24 hours, you can still consider TPA. And so that's why it's always important from a pre-hospital or emergency room standpoint to identify when the patient last was normal. And I think over my 30-year career in EMS, in different capacities, I've definitely seen us change our approach. There's a much higher leniency for getting these patients into an interventional lab or starting TPA if there's no other contraindications to do so. If we think about TPA, right, Activase, it's important when you transport these patients or you dose these patients to understand, number one, how they're dosed, how the medication is supplied, and some problems that you may have if you don't confirm these different types of areas related to this drug. So for ischemic stroke specifically, the max total dose is always 90 milligrams. And that's obviously weight-based, but we never exceed that. So one of the things that we always want to do, most hospitals have great protocols that take care of this, but I want to know when I'm taking care of a patient, or I come in to transport a patient, has that extra 10 milligrams been removed from the bottle? Because TPA Activase is supplied at 100 milligrams. And that is because in for example, a PE setting for those treatment regimens related to PE, 100 milligrams is going to be the max dose. So in an ischemic stroke setting, you want to take out that excess drug. So how do we dose this? For example, if we have a 70 kilo male patient, the dosing starts off at 0.9 milligrams per kilo. So 0.9 milligrams multiplied by 70 kilos is a total dose for that patient of 63 milligrams. So that's what you want to start off with. And then what you do is you take 10% of that dose, and that's going to be administered in a bolus over 1 minute. And so, for example, this patient at 63 milligrams total dose, 10% of that is 6.3 milligrams. We're going to administer that over a 1 minute time period. And in a hospital setting, if you're in a transport mindset, you show up and this is usually taken care of before you arrive. And then we have to give the remaining amount over 1 hour. Well, we have 63 milligrams as our total dose. We've already given 6.3 milligrams as our bolus. The remaining amount should be 56.7 milligrams, and that should be administered in an IV pump over 1 hour. The key is when you arrive at that receiving facility, to give a good, thorough report, talk to the receiving nurse or doctor that's there to receive the patient. You know, if you still have medication left over, you're not quite done administering the drug, you need to have a protocol in place. How you're going to handle that? Are you going to move that drug over to their pump? If you are, how are you going to do that without getting rid of any medication or wasting any medication? A lot of times, if I only have 3, 4, 5 minutes left, I'm just going to stay at the bedside and let that infuse in and be done with it. I think it's much easier to do that. The key, though, is good documentation, documenting all the aspects of the drug, looking for any reaction, watching the patient from a Glasgow Coma scale, reassessing the NIH stroke scale or Cincinnati stroke scale, whatever you have available to you. And then really, I want to focus on blood pressure. How do you handle a blood pressure? Really, the treatment goal for ischemic strokes are a little different than a hemorrhagic stroke. Hemorrhagic stroke, we know for a subarachnoid hemorrhage, we want to keep a systolic blood pressure at 140. But when we compare that to an intraventricular hemorrhage, we have blood in the parenchymal areas, in the ventricles specifically. 160 systolic is our goal. But we know ischemic stroke patients are a little different. And we have a pretty huge potential. We want to make sure our perfusion is a little bit higher. And so in those patients, right, we're not laying these patients in a semi-Fowler position. We're laying these patients flat, whereas in a hemorrhagic stroke situation, you can lift the head of the bed up. But really, our goal is going to be to get that blood pressure down to 180 over 105. That's usually the standard approach. And so a lot of these ischemic stroke patients have longstanding hypertension that's uncontrolled. And if their pressure, on arrival is, let's say, 220 over 120, it's always a big conversation piece. I know from my experience in the flight environment, if you treat that or not. And I think from a scene flight standpoint or a 911 call standpoint, the important part is, do you know where their norm is? Maybe they sit that high, and that's the thing. And so I think I tend to be very conservative when it comes to treating blood pressure in an ischemic stroke situation. I think unless I have really long transport times, I might treat it if it's in the 220s range and get it down to that 180 over 105. But if I have a really short transport time, I may not. And that's something that really goes against. I'm pretty aggressive in a lot of areas of treatment within our guidelines and protocols. But that's one area I try to stay a little bit more conservative on. And I think it's just safest to do that. But really the goal is to maintain a MAP less than 130. Again, systolic of 180, diastolic of 105 is usually the treatment goal. And to achieve that, we have a few different medications that I want to highlight. I think the best medication is nicardipine or cardine. Great drug, used a lot in stroke and hemorrhagic ischemic stroke settings. Start with 5 milligrams an hour, increase it by 2.5 milligrams per hour every 5 to 10 minutes to a max dose of 15 milligrams per hour. There is expanded protocols for longer transport times where if you do achieve a blood pressure target or a MAP target, if you've maxed that drug out at that point, you don't want to keep it maxed out. A lot of places will then decrease this back down to 3 milligrams per hour and then titrate it up accordingly based on how the blood pressure responds. Great drug. I've had amazing success with this drug. I've never seen any poor reactions. I've never seen, any huge fluctuations in blood pressure. Another drug that we should touch on is labetalol. Labetalol is used all the time. I think it's a very easy drug to use. A lot of people tend to grab this in the med box a lot of times over a drip just because of the ease. They don't have to mess with the pump. For me, I think cardine, most often is already pre-mixed and there's really no need. And so really 10 to 20 milligrams IV push every 10 to 20 minutes, max total dose of 300. And this is given in multiple ways, guys. Honestly, I see ERs that will just give repeated doses of 20. In the flight environment, what we've always done is whatever starting dose we start at, if we started at 20 milligrams, the second dose at that 10 to 20 minute mark is going to be double that. So we would go 40 milligrams. And then if we do another dose, we would double that to 80 milligrams. And then you never, ever exceed a max dose per single dose, I should say, of 80 milligrams until you reach that 300 mark. I see ERs do it completely different. So again, this is just one way. I try to always teach multiple ways, but it's going to be based on medical direction or in the ED, how it's ordered. In summary, guys, 70% of all ischemic strokes are within the anterior circulation. Remember, and then 90% of those anterior circulation strokes are inside that middle cerebral artery. 75% will encompass embolic etiology. So that's the most common. And then when we think about assessment, it's about early recognition. It's about identifying if this patient is a candidate, if this patient is symptomatic from an ischemic stroke etiology, and getting them to the correct facility. Remember, it's all about time. And so don't ever hesitate to use aeromedical if you deem that it's quicker to get that patient to a level 1 stroke center. And obviously from an assessment side, very thorough assessment is using that NIH stroke scale. And it provides a quantitative measure of stroke-related neurological deficit, looks at total outcomes and treatment modality. And then obviously when we think about posterior circulation strokes, a huge portion of those are encompassing the basilar artery, which carries a really high mortality rate. And we know the basilar artery feeds a lot of blood into that total area of the circular Willis. And guys, if you have any questions related to this lecture or anything else, if there's anything you want to see within content creation, please email me at eric.bauer@librogid.com. And I will talk to you on the next module.
Hey, thanks so much for joining us for the webcast today. We hope that you learned something new and helpful that you can immediately apply to your practice. Before we share the QR code that you can use to register to get your 1 free CE hour for participating today, we wanted to share some exciting news with you about a huge project that we're launching next month. And as always, we can't wait to see you back in June for the next installment of our webcast series. Stay safe out there, and we'll see you soon.